Hi there, I'm Dr. Robert Reed, Primary Care Medical Director for THN, and thanks for joining me on this little chat about morbid obesity and malnutrition. First, a few words about morbid obesity. Morbid obesity has steadily increased in prevalence over the last 50 years or more, particularly over the last 20. For the first time in our history, the U.S. adult obesity rate has risen beyond the 40% mark to 42.4%. We also now have an incidence of morbid or severe obesity of 9.2%, and that reflects a 146% increase since 2010 and a 195% increase since 2000. Obesity is expensive. It costs almost $2,000 more per patient in annual costs, and it's estimated that we'll spend about $210 billion on obesity-related expenses in the next year. So what value is placed on the diagnosis of morbid obesity? Well, CMS chose a RAF coefficient of 0.250. What's that mean? Well, it means they think it predicts future financial costs that are going to be more expensive than breast or prostate cancer, more than chronic hepatitis, and even more than an acute MI for our patients. So they take this very seriously. Now, despite this, morbid obesity often goes undiagnosed. How is this possible? Well, several possible reasons come to mind. First, I think that this diagnosis is hiding in plain sight. Over time, the percentage of our population with morbid obesity has so gradually increased, we've become accustomed to seeing patients in this weight range and not viewing it as abnormal. Second, as providers, I think it's more rewarding to identify medical problems that we can directly treat. We have medications for all kinds of diseases, but very little effective long-term treatment for patients that weigh more than they should. It's harder to identify and discuss a medical problem with our patients when there seems to be so little we can do to help. Finally, a third reason that comes to mind is the fact that many of our patients see the word obesity as an emotionally charged term, not just a medical diagnosis. They may have struggled to lose weight their entire life, and when they hear this term from their trusted primary care provider, they may feel shame rather than informed. So what can we do about it? Well, it's up to us to help them see the importance of addressing morbid obesity and the danger of leaving this diagnosis untreated. We need to point the way to treatment options that range from meal plans to gradually increasing exercise, behavior change, medication, and surgery. And if we don't have the knowledge base to help them, we need to be able to refer them on to someone that does. We need to take the sting out of this diagnosis and treat it like any other medical problem so we can follow up on the patient's progress each time we see them in the office. This gives us a chance to celebrate our patients' successes when they lose weight and to help them explore other options without condemnation when they don't. We become their valued medical counselor and accountability partner when we address and not ignore morbid obesity. Okay, now you know why I believe we should treat weight conditions as important medical problems and why we need to spend some extra time addressing these concerns. You see, RAF is not only a predictor of our patients' future financial costs, it also brings in revenue to compensate us for the time we'll spend working with our patients on these problems. So, how do we make the diagnosis? Finally, we're there. Two different ways. First, the easy one, and that's if a patient has a BMI of 40 or greater. This is a slam dunk. You enter the diagnosis code for morbid obesity, and you optionally add the Z code for their BMI. After that, under the diagnosis of morbid obesity, you add some treatment recommendations, and you are done. The second way to diagnose morbid obesity is not as obvious, particularly because the patients don't weigh as much. These are for patients that have a BMI between 35.0 and 39.9. First thing you do is you enter the V code for their BMI. Then you enter the morbid obesity code. Now, here's where it's a little different. You link that morbid obesity code to at least 2 obesity-related comorbidities. You do that by adding a note to the HPI, or enter information in past medical history, or attach those comorbidities to the assessment of morbid obesity. I'll give you more details in a bit, though. That's just a primer. When you complete that, you add the treatment recommendations. So what are those comorbidities? Well, these are anything that can be affected by the patient's weight. And I have just a partial list in front of you. Anything from different kinds of cancer, congestive heart failure, depression, gallbladder disease, gout. I mean, you name it, there's a ton there in front of you. And I won't go through all of them, but they all are comorbidities. To make the diagnosis of morbid obesity in this weight group, you need to have at least 2 comorbidities attached to the diagnosis. Now, let's spend some time talking about weight problems on the other end of the spectrum, and that'll be malnutrition. Ironically, as morbid obesity has increased in prevalence, so has malnutrition. It's estimated that up to 50% of older adults in America are at risk for this disease. And malnutrition is associated with decreased bone health, increased frailty, increased risk of falling, higher incidence of hospitalization, and increased mortality rates. So it's important for us to identify these patients and also encourage them to eat a higher protein diet. Now, the ICD-10 code I chose was 46.0, but all malnutrition codes have exactly the same RAF value, which is 0.455, almost twice morbid obesity. So it's a very important diagnosis. How do we make the diagnosis? We can make the diagnosis by following any of these criteria. If the patient has a BMI less than 19 and they haven't been that weight all their life, this is a drop down to that level. Or if their albumin is less than 3.0, or if their protein level is less than 6, or if they've had recent unintentional weight loss to the tune of more than 3% in the last 3 months, more than 5% in the last 6 months, or 10% in the last year or more. All of those meet criteria for diagnosis of malnutrition. Additionally, if as a provider you feel the patient has a gaunt appearance, they've got muscle wasting in their hands, their thenar eminence, and you believe that they have malnutrition, that is all you need to make the diagnosis. Nobody will question you. So you simply put that in your HPI and make the diagnosis. Let me mention that this code is frequently missed in office visit notes, even when the provider notices these changes. Please don't let that happen to you. If you notice the changes that are associated with malnutrition, make the diagnosis. Let me share with you now what I consider to be the best way to never miss a diagnosis of morbid obesity or malnutrition. Ask your assistant, the one that enters the patient's vital signs, to also add the ICD-10-Z code that's based on the patient's weight. In this example, the patient has a BMI around 36, and the Z code Z68.36 is entered for you. That way, the BMI is going to be a reminder as you begin entering the other diagnoses that you'll come up with during the visit. As you enter those diagnoses, you'll glance over and notice the patient has a BMI greater than 35. Oh, potential diagnosis of morbid obesity. Look around and see if you find 2 diagnoses that could be the comorbidities to finish out that diagnosis. If you find 2, link it to the diagnosis of morbid obesity, and then finish by adding a plan. I've just added a simple one here that says weight loss through decreased caloric intake and increased aerobic exercise recommended. But of course you can expand on that as much as you like, and certainly expand on it when you're talking with the patient. All right, final slide. You made it. You made it all the way through. But before I leave you, I told you I'd give you more details about linking. So in the world of morbid obesity, for those patients with a BMI between 35.0 and 39.9, you need to link the diagnosis of morbid obesity to at least 2 medical conditions that are affected by the patient's weight. I gave you that list earlier. I won't go through that again. Easiest place for the coding educator or auditor to find this linkage is on the assessment line. Right next to the morbid obesity diagnosis, you add associated with, and you put those two comorbidities right one after the other. Now, other acceptable places in the progress note are an HPI. If you mention that the patient's blood pressure seems to be worsening associated with his morbid obesity, boom, you just created a link. Also, in past medical history, you list the diagnosis with the associated comorbidities in a linked manner. And that's saying something like morbid obesity associated with hypertension and hypercholesterolemia. That associated phrase links those all together. Okay, well, we're done. Thank you for hanging in there with me through this whole presentation. I hope you learned something. If you have questions, please let me know, and thank you for your attention. Bye-bye.